Perfect. Okay, you guys are live. So go ahead with your case presentation.
Perfect. Good afternoon, everyone. Thank you to PK for giving me and Karthik the opportunity to do this live case. So we're going to present a Iliac case, which our fellow is right here, David Song. We have Liz as our nurse. We have Josh as our tech. And Roby's out here too. So we're going to start with the live case presentation, and then we'll show you the picture. So, David.
Good afternoon, everyone. We have an iliac intervention case to present today. Next slide, please. So this is a 73-year-old female referred for progressive bilateral lower extremity lifestyle limiting claudication that has been progressive to rest pain, right versus left, Rutherford grade 2, category 4 over the past 8 months, despite optimal medical therapy and supervised exercise therapy. Her ambulation is limited to less than 1 city block. She has multiple comorbidities, hypertension, hyperlipidemia, diabetes. Of note, she has had previous intervention for a peripheral arterial disease. This was done at an outside hospital with unknown details. She is a former smoker and she is on good medical therapy. Next slide, please. Next. In terms of non-invasive diagnostics that have been done, she has severely abnormal ABIs on both sides with monophasic waveforms that are diminished. In terms of her arterial duplex that was done at an outside facility, she has peak systolic velocities that suggest bilateral iliac stenosis with multi-level disease. Next slide, please. She has had an outside diagnostic done that shows bilateral osteocommon iliac disease with multi-level disease. Next slide, please. In terms of our case plan today, the access is bilateral CFA access with a 7 French 25 sheath and also left radial access with a pigtail in order for injection and hemodynamic monitoring. In terms of adjunctive therapies, we're going to use IVUS guided imaging in order to size IVL for shockwave, and our destination therapy is ultimately going to be a balloon expandable stent with Viabond VBX and of the bilateral iliacs with the KBI.
Perfect. All right. Thank you, David. So we just wanted to highlight this case. I know it's not like Dr. Metzger's critical CTO, AO2 iliac disease, but something like run-of-the-mill, which you'll really see classically in patients who have the complexity of having calcification in there, which needs to be treated appropriately. So I guess our goal, both me and Karthik's goal, was to demonstrate the lesions here, and then, of course, decide on the therapy, and we can discuss options. The only thing to add is we took a left radial access for better visualization of the arch, because we were suspecting that we'll get a bifurcation lesion where we might have to do simultaneously stenting as well. So that was the thought process. But we'll let Karthik.
Yeah, just a quick question before you start. Any reason why you guys didn't consider CTA?
So usually, well, again, we do CTS, but in this case, the clinical symptoms, the presentation, the ABI, and everything was so convincing that we directly went for and they had the previous diagnostic from outside. This was more of an outside referral. Gotcha. So we already had those diagnostic pictures, so we didn't have to go back and do a CTO. We did know the lay of the land, so that's the reason we called the patient in for intervention.
Sorry, go ahead, Karthik. Go ahead.
Okay. All right. Perfect. So what we could do is we actually did the IVUS measurements on both sides. So you can let's start with the pictures first, and then we'll go over it. So you can see. I don't know if can they see our pictures?
Yeah, we can see your pictures.
So this is perfect. So this is the angiogram. Like you can see, it's a significant disease, significant calcification on the left common iliac, and also involving the right side. The right side has essentially 2 spots, but overall it's very calcified lesion of the iliac. The rest of the iliacs are nice and look beautiful, at least, especially the luminography per se. Karthik? Yeah, so you can see the CFA accesses were nice and robust, so that was one of the reasons we're getting it. But there's also multi-level disease downstream, which probably needs to be fixed once we fix the inflow. So the next picture you're going to see, the patient has significant distal pop and SFA disease bilaterally and barely 1/2 to 1 vessel runoff in both the legs. So I think that's what explains the significant drop in ABI and significant, almost like Rutherford rest pain is what it is. So here you can see the SFAs look good, but as in how, especially the mid-side starts to show up with significant abnormality, and the popliteal has almost subtotal total occlusion and a very poor runoff, both below the knee. So the multi-level disease is what's presenting in this patient the symptoms. So the idea was to improve the inflow by fixing the iliacs and then hopefully bring them back and do rest of the lesions as well.
So I'm
I have
going
a mic, sorry.
to ask
Okay.
the panelists how would
So
they
any
approach.
comments how to approach? Go ahead.
Yep. I was about to ask the panelists that to see how they would approach this case.
I
You
would
turn on the mic, guys.
I would like to add IVUS and just see what kind of plaque morphology we've got. And I think we've talked about it up here earlier. I think it's also important to note that although it seems like it's exclusively common iliac, it would be nice to go up into the aorta and just make sure the aorta isn't also involved. Because I think depending on plaque morphology and what all is involved in terms of complexity at the bifurcation, that should lead you to choose your next piece of equipment.
Yeah, I think that also applies to the shockwave as well too. I mean, the L6 is nice, but it might be overkill in this case potentially. So you could potentially just get away with a couple of covered stents and be done with the case. But I think IVUS will help inform that information.
So, is there any
Right.
specific
So I think
IVUS
that's what
criteria you guys
Josh, I
use to
think.
say this needs shockwave, this does not? Is there like 90 degree, 270, or 360?
Yeah, I mean, obviously IVL is more effective when you have concentric calcification. Eccentric, it's less so. And I mean, you know, if we're talking about reducing the risk of perforation and whatnot too, even though that's not necessarily been borne out yet in studies, you know, you are going to be using presumably covered stents here. And if so, you could potentially get away without doing IVL in this case. And I think maybe the IVUS might help you decide that.
Yeah, and I think where the calcium is, you know, how extensive it is it really part of the lesion that's obstructing the lumen and you need something like IVL to push it out of the way to get full expansion of your stent? Or is it medial? Is it very, you know, there's also thick calcium versus like more spotty. So, you know, my question would be, I'm not even committed to covered stents at this point. I mean,
Wait.
no, I'm serious. I mean, if you see like 90 degrees and it's not that calcified, why not just use a...
These are not task C and D lesions. These are task A lesions. So you could make a case that these should be treated. You know, your CFO is not going to be after you because you're treating with the least expensive thing. But that brings up the question of, you know, again, should you be using shockwave in this as well?
Yeah, so that's a different argument completely because I don't think we've studied that either, right? So, I mean, I do believe that shockwave does improve the safety of the procedure because you're changing that morphology. You know, people who end up with those, you know, indiscriminate ballooning or stenting, they end up with a big perforation afterwards. We see those classic pictures, but a lot of those things were pre-shockwave. So it is possible that you can make the vessel more compliant, make it safer to expand, and that could potentially change the whole nature of the case. But, you know, I guess we don't really know that yet. And you have the added cost there, of course, but there is reimbursement.
I mean, I would say with that appearance, I don't think shockwave's that effective just because it's eccentric and it's bulky calcium. I agree with you if it's like a circumferentially calcified, you know, lead pipe type vessels that you're not going to be able to open up stents. I think there's a role for shockwave, but I wouldn't use it here. I'd save the money on the shockwave and put the 2 covered stents in and kiss them at the bifurcation.
I got to say, I think
I think I would go for a non-covered stent actually. Uncovered stent.
uncovered.
Bare metal. If you look at the recent data from the Dutch randomized trial, the Discover trial, and also look at the data from the COBEST for task A and B lesions, there's no real benefit except for the maybe lower risk of embolization and perforation. But if you perform your measuring up front or during the procedure properly, then the risk of perforation is very low. If you have, however, would use IVL, then the question is, are you going to use a kissing IVL or are you doing a sequential IVL?
I think the other thing that I look at when I'm looking at calcium and deciding on lithoplasty is basically how extensive is the calcium? You talked about that, and how much of the lumen is compromised by that calcium as well. You know, if this is 95% occluded, it's hard to tell from the angiogram, but this is really significantly impairing the lumen itself. Even though it's eccentric, I actually think IVL helps here and allows you to better expand the stent. So I think either That's why I think having axial imaging, whether it's IVUS or CTA, is critical in decision-making here.
I think Dr. Finelli wants to say something.
Okay, so I think all the points were amazing, and I think we did the IVUS. So the confusing parts come.
Karthik, Vishal, just give me 1 second. I think Dr. Finelli was asking whether you guys going to do the iliacs first and then come back in a staged fashion for the SFA pop, or are you going to try and do that at the same time?
So we are trying to see, because she's having just lifestyle limiting claudication, we want to see if the iliacs will take care of her claudication. So we're going to fix the iliacs and probably stage her for intrainguinal lesions if needed. Right.
I mean, with the ABI of 0.25, that's consistent with almost CLI.
No, I mean, we have to do it. I mean, most likely 0.25 is from the multi-level disease he has, but again, it's claudication, right, at the same time. So, but if you have inflow iliac lesions, we'll do that. Usually our practice is to monitor them for a month and see how they feel. And if the symptoms, based on the symptoms, we decide how aggressive we have to be with intrainguinal lesions.
I think I agree with Karthik. I mean, the biggest thing is the reason we presented the case is the amount of discussion we have. You know how people have knee jerk to do shockwave as soon as they see some calcium, iliac, let's do it because it's becoming more in fashion. And also the reflex of putting in covered stent. But I think the panel had a great discussion of using all the way from no shockwave to covered to non-covered, straight up balloon expandable. But I think we'll show you the IVUS and you'll see that sometimes how angiography can underestimate. You know how we read tram track calcification and we get scared, but we can also miss calcium by not doing IVUS. And again, we come back to the point of how much IVUS can give us an extra set of eyes and help us make a decision. So let's quickly see the IVUS, please.
So this is the left eye. We did the IVUS of the left lesion first.
Can you play it?
So play it.
So this is from the distal aorta coming into the left common femoral?
Yes. Yeah, we did go into the distal aorta.
Distal aorta coming into the left common.
Okay.
So you can see the calcification right there. I mean, of course, it shadows down, but here you can see almost 270-degree arc calcification. We come to the common, and right there, I mean, here is more eccentricity. Look at that lumen.
That's nasty.
So it's nasty lumen, which doesn't look that bad on angiography. Again, you can see the calcification all the way around. And then the calcification, of course, is minimal here because we're coming to more to the common external side. So we'll look at the IVUS, and then we'll get the panels again thought of whether they want to revisit the idea of doing a shockwave, or still they hold true to their first commitment of just straight up covered or non-covered without shockwave. This is the right side now. Again, starting in the distal aorta, like Karthik said.
And so just to make things interesting, Vishal, we're going to move to Tennessee after we review the IVUS with Dr. Metzger's case, and then we'll give you time for what you guys plan to do and see the finish.
Right, so you can see that luminal compromise again.
So the right actually doesn't look that bad on the angiography, but it has a very eccentric calcified lesion.
So how many are now in favor of shockwave, how many not?
No, I think it's reasonable now, seeing the morphology.
Yeah.
Yeah.
So I think our plan initially was to shockwave it, see how you do, and get away with bare metal self-expanding stents. To do a bifurcation self-expanding stents, not use a covered stent with the focal morphology we have after the shockwave. So the question we had for the panel is, what kind of, what size of shockwave would you guys use here? Can we use the reference images, please?
So just to keep it short, we did 8.6.
Sorry, Vishal. Vishal, we gotta come back to you.
Okay.
Karthik, sorry, we'll come back to you. We'll just get Dr. Metzger. Yep. We can go to Kingsport, Tennessee. Vishal, can you hear us?
Hi, Bhaskar. All right, so.
Yeah, go ahead. What did you guys do?
Okay. So like we said, after the IVUS, we decided to use shockwave because the IVUS showed significant calcification. So as you can see in the pictures, that's our 8.0 shockwave. We almost sided 1-to-1. So we did the left side first beginning. And you can see it's a well-expanded balloon, so it did respond well to it. Then we went to the right side. So we did sequential.
Used a lot of cycles.
So, and then we...
IVUS, guys?
Well, let's show us the IVUS. So we did an IVUS after that, and we're going to show you pictures. So this is the left side again, starting in the distal aorta.
Yeah, I can see the calcium's fractured
And
pretty
then
well.
you can see, look at that. You want to call it recoil, or the shockwave didn't work, or we didn't need a shockwave to begin with? I don't know.
Because the vessel size, reference size is around 8.0. So we use 1-to-1 actually.
1-to-1, yeah.
Yeah.
not-
So the
not
next
s-
IVUS for the
Not
right.
surprising since it's bulky, eccentric plaque to have
Yeah.
that
Right, so
similar
that's-
appearance.
And you're
after
also
you do
not expecting that, I mean, I'm not expecting that lithoplasty is going to make this vessel look normal. When I do this,
Right,
I'm
right.
hoping it's making fractures so I can more easily compress
Yeah.
the plaque with a stent
Yeah.
that I'm going to put in afterward. I've kind of
Yeah,
made the
and
decision.
this is
ahead
your
of
right
time on
side.
the Stent.
Yeah, I think regardless of the appearance, you'd stent this no matter what. Yeah.
Yeah.
Right.
The question is, we were very hopeful that we would go with bare metal self-expanding
So
stents.
this is
But
a
now
post-IVUS image now. You can see the calcification.
Do you guys have
still
any
there.
suggestions?
I'm
This is a
biased
post
in favor.
IVUS.
So suggestions regarding the stenting technique or the
Would you
kind of
would you
stent?
guys use a?
Yeah.
I mean, we used a 1-to-1, but would anybody have used a smaller size or?
No, I think that's okay. But I think with what you're seeing residual, I don't think it's unreasonable at all to go with the covered stents.
So we saved some money on the IVL. We used the same IVL on both sides.
I probably.
But I think that's what we were leaning towards.
use an uncovered stent.
Still bare metal.
I would because
balloon expandable?
this is a task A lesion. This is a really short, and the real issue is whether covered or uncovered. The issue is, are you going to get adequate expansion? And
Nito.
I would just use
Nito
an
39.
uncovered stent here.
So I have a question for the panel, and I mean everybody's talking A, B, C, and D, right? Now, so you have the discovery trial that shows that the bare metal stents are as good as the covered stents. So, I mean, does it make a difference with the newer stents and the newer stent design because the older stents are different?
Nito 39.
And that's why I'm curious here. I agree with Dr. Clara that this is probably in our hands will be a bare metal stent, but it's almost reflex to look at these lesions and say, oh, they're calcified. Let's put a covered stent.
So if you look at COBEST, the only difference really in COBEST was C and D, not calcium, not anything else. And the other thing, if you look at COBEST, there's a huge drop off, like in the first 3 months between the A and B and the C and D. And I actually think a lot of that is due to like your hesitancy to dilate a really complex calcified lesion with an uncovered balloon expandable stent. That drove, there's further separation later on, but I think early on, you need to be comfortable that you can dilate it to an adequate size and that you're getting adequate expansion, with what you do. But I have to admit, I was after COBEST, I was using covered stents more than I am now. I've kind of gone back to using a lot of uncovered stents because I think they work pretty well. In fact, Sean Leiden at Cleveland, we for a long time were proponents of using uncovered stents for pretty much everything. I'd kind of switched after I'd left there based on the late COBEST data, but they published some data, and it's not randomized, but it's very good patency on uncovered stents for almost everything they use for very complex aortoiliac disease. And I feel like I have the same thing. I think the issue is getting adequate expansion.
And I think that's key. So I think you need a balloon expandable stent here, whether it's covered or bare metal, probably doesn't matter that much in the end for this particular lesion. But I think balloon expandable is a way to go. Self-expanding is not going to work with the eccentric lesion.
So Darren, with the the ICE study, I mean, in the comment, it was almost opposite to what you and I think, and that's why I worry. Like, are we putting a lot of weight on the appearance of it rather than the hemodynamics of it, and do we just sort of accept a suboptimal result as long as we have hemodynamic, resolution?
I mean, that's what the ICE study showed, that there was effectiveness of these self-expanding stents, and maybe more so. I still think that it was lack of aggressiveness with the balloon expandable stents.
That's why you showed the difference.
That make the difference. So I mean, I want to make sure that with the balloon expandables that I get adequate expansion. But I do think that you benefit from, in terms of precision, and also being able to use in the kissing technique, and also having that radial force with that eccentric calcified lesion, that you're going to get a better result with balloon expandable here.
I think the other thing, PK, is that the subgroup analysis favored balloon expandable and calcium, but they weren't very specific about the kind of calcium. And I think that's, I think here we're all getting caught by that one area of really eccentric calcium, and that may be making us think differently.
To elaborate a little bit more on the Discover trial, the Dutch trial, where they looked at uncovered versus covered, what they did, they didn't use IVUS because that's not available or reimbursed in the Netherlands, but they did use intraarterial pressure measurements on several occasions during the procedure. And what they actually showed is that you need to do more with an uncovered stent. You need to get it right. It's less forgiving than using a covered stent. Probably you can still leave some residual stenosis with a covered stent, and that is also probably the reason why in the COBUS trial, in the A and B, task A and B group, there was this drop within 30 days, all related to imperfections of the initial procedure.
So, Vishal, what do you guys have? 2 VBXs there?
Yeah. So that's what we decided. I know we talked about task A lesions and the compliance and the elasticity, but having that circumferential calcium and eccentricity, we would just wanted to be on a safer side, and I guess use covered stent in this case. I think the patency rate of covered stent here will still remain good, especially if we expand it all the way 1:1, and with hoping that there's good outflow. That should not be a big limiting factor in our decision. So me and Karthik pretty much.
No, I just wanted to ask panel a question. We used an 8.0 IVL. The vessel reference is around 8.4. So if you're using a bare metal stent and it's underexpanded, which most likely it's going to be, so how aggressive are we going to balloon? We can't use a 9.0 in an 8.4 vessel with a bare metal stent.
You said you can't
So
use a
what would the
9.0
panel do?
Why not?
I mean, that's too, I mean, I'm just saying based on the iliac aggressiveness, if I use 9.0 in a I'm
So then
risking it for perf, right?
What you might do if you're anxious about that is just put in an 8.0 stent, put that in, and then you can post-dilate with a 9 or a 10 balloon if you have to. But I wouldn't hesitate to put a 9.0 in here if you thought you got reasonable dilation of your lithoplasty balloon. And the other thing is, I think I see PK in the back calling your CFO about using it.
So is this a 8 large or just a regular 8 VBX?
Regular 839 VBXs.
So the VBX, I mean, if you can go really high on that too. It will expand beyond the reference, so you won't even need anything else.
Right. Exactly. That's what we thought. All right.
So do you guys deploy it right at the ostium? Do you push it up a few millimeters? What's your technique, Vishal? How far do you extend it?
Let me go again.
Pull back a little bit.
Yeah, I'm gonna pull back.
I think that's a good angiogram that shows, this disease oftentimes it's not just the iliac artery, it extends into the aorta there too.
And that's generally why I would extend this about 5 millimeters or so above the bifurcation, because the last thing that you want to do is have a technical issue right at the leading edge. That's why these things will fail.
Yeah.
And I don't think it makes a difference. I don't want them crossing. I don't want to cross them over, but you can extend it 5 millimeters without the stents.
That's exactly what we did. We just extended 5 millimeters exactly into the aorta because I think it looks like the distal aorta has some calcification also.
And even at that distance, you can
misstudy.
still cross over the aortic bifurcation
Yeah,
easily.
absolutely.
Yeah.
That angle is totally fine.
Go up again. Go up again, guys.
Yeah.
It's okay. Go up again.
Pressure.
And sometimes what I'll do is I'll take these balloons up a little bit and just dilate them to make sure that I'm getting adequate expansion of that distal aorta.
I know.
Yeah, I do the same thing. So after this inflation, the post-dilatation, you just go up a little bit, a few millimeters in the aorta, and do another inflation as well.
And the sizing of the balloon, will it be determined based on by the size of the distal aorta? Or do you just size it according to the stents?
I'd size it based on the stents. The other benefit of doing this advancement in post-dilation is you can be much more aggressive without worrying that with your shoulder on the distal end that you're going to create a distal dissection.
I mean, if you were worried about that, that would mean that you would probably need a container stent above. So in this particular scenario, that's not going to be necessary.
So, Karthik,
Yeah, we went to 16 and
16,
we went up into the aorta a little bit.
And so you basically use the stent balloons
I'm
itself.
going to take a quick picture. And,
We're going to take a quick picture and
Yeah.
see.
all right, ready?
What do you guys think of IVUSing after the angiograms, or depending on what the angios look like?
Yeah, that's the plan.
Oh, it's beautiful.
Looks great.
So
think
Karthik
it's a
and Vishal, what we're going to do is we're going to go to Kingsport, Tennessee, see what they're up to. And if you guys decide to IVUS, we'll come back and take a look. Okay?
Yeah, yes, that's what we're planning.
Sorry, they're having an issue. So we're going to stay with you.
I think the other
All right, it's all
benefit in this case of going 5 millimeters above, because you can see when you post-dilated that, there can be a little bit of foreshortening of these stents, and that could have been the issue
Yeah.
in Kingsport where it foreshortened, and they were a little short on the proximal end, so that gives you a little bit of an insurance policy against that.
So Darren, just a question for
yeah.
the panel, Joe, Yos, and as well, is that when you guys go into the aorta with these post-til balloons, obviously it's 8 and 8, it's a smallish diseased aorta. Do you worry about causing a retrograde dissection in the aorta, or because with the 2 balloons? I mean, is that something without any axial imaging, like in this case? If you had axial imaging, you probably could be a little more confident.
So I have a couple of times had a dissection. It doesn't extend proximally. I mean, but you can dissect that distal aorta some when you do that. So I'm not going for a massive, and that's why I'm not taking the size of those up further than, I'm not putting 2 10s in there with 8 millimeter balloons. But I actually,
Give me the one.
that
Give me another one.
angiogram that they had at the end was really a good example of, they actually dilated that distal aorta some. And I usually do that as a pretty extended inflation. Like I'll leave them up for 3 to 5 minutes. I don't just put them up for 30 seconds and take them down.
I just had a question about measuring pressures. Now, I think we're measuring pressures as a surrogate of flow, but it can be falsified depending on what your resistance is distally. And that's why you have normal ABIs, even with normal resting ABIs with aortoiliac disease. So how credible is that to measure your adequacy of treatment?
So we were just.
If you want to do it correctly, then you should give, you start measuring. If you obviously measure a gradient, then you still need to do something. If you don't measure a gradient, then you still need to give some vasodilation in order to give a kind of walking exercise.
Almost like your iPhone.
We had been talking about measuring gradients here because, when Chris did an angioplasty through that iliac artery, he completely eliminated the gradient.
Yeah.
The gradients should make you feel good that you've helped things, but they don't. The absence of a gradient doesn't mean that there's that nothing is wrong. It just means that in this setting there isn't a difference. But yeah, I wonder in situations like that though whether even an induced gradient, whether you might even not be able to induce a gradient. I think the real issue is you've got to make sure anatomically you have good inflow and good outflow. You can't just, having a flap in there that is moving around is going to be a problem long term too.
Vishal, I think Kingsport is live, so we're going to switch to them and come back to you.
Okay. Measure
Did a post-dilatation 8.0. We went almost up to 16. We did an IVUS. We'll run it for you to give you an idea. Can you please run it? This is the left side to begin with.
So this is post-stent, post-dilatation, right?
Post-stent, post-dilatation with an 8.0. Yes, the stent balloon going all the way up.
Hold it.
Okay, so
That's the left side. Looks well expanded. I mean, with the dimensions were a little bit on like 7, 6, 7, 8. If you can play the other IVUS as well on the right side. Perfect.
and this is the right side?
This is the right side. So you can see it's right at the bifurcation. The stent is well expanded. But again, it was a little bit of underdilated. So we actually went with a 9.0. You can see it's like a 7.0 distal measurement, 6.9 to 6.9. So we did go up a little bit more aggressive with a 9.0 20 balloons.
Run the
bilaterally.
IVUS. Run the IVUS live, please.
And then this is post. We took some pictures. This is after the 9.0 ballooning. And then we can run the final IVUS for you just to see how well it looks expanded. But this is the right side. Can you play? Yeah, start recording. So here you can see it's much better expanded from
very
an
nice.
8.0 with using a 9.0 post-til balloon. And distally it looks okay with no dissection.
You know, that's like such a great example of how the stent can look completely normal in the AP plane on the angiogram. And the IVUS really shows you were missing 50% or so of your lumen that you straightened out. This is awesome work. I mean, that's great.
This is after the 9. Yeah, after the 9 O's, we got almost 8.2 lumen.
Yeah, it was like 6.9. So.
It was 6.9.
So again, same thing with the IVUS really helped us in the case in regards to the calcification, the sizing, of course, and like you rightly said, regarding the
Go live on
after
the IVUS?
stent implantation to see we have good results. So, and we're just going to quickly go on the left side just for
Yeah. Karthik, Vishal,
patient's sake.
thanks a lot. Thank you. Appreciate it, guys.